Good afternoon, everyone. I see people are still joining us, so I'm just going to give people a minute to fill up the online lecture hall. All right, well, we might get started with that. Hello, everyone. My name is Brendan Clifford. I'm the Research Coordinator for the Alcohol and Drug Service at St. Vincent's Hospital in Sydney. I'd like to start off by acknowledging the Gadigal people of the Eora Nation as the traditional owners of the land on which I'm working from today, which always was and always will be Aboriginal land. And I'd like to introduce Dr. Chris Tremonti, who you may know as a very capable chair of this DARIA session on other occasions. Dr. Tremonti is an addiction physician and a clinical pharmacologist who works as a staff specialist at St. Vincent's Hospital in Sydney. He's currently undertaking PhD studies looking at long-term health outcomes of heroin dependence at the University of Sydney. This DARIA session is on how we do drug testing in addiction medicine, and it's got some very interesting clinical implications that he's discussing with that as well. So without any further ado, I'll hand over to Chris.
Thank you, Brendan. And yes, I should add, as I was saying to Brendan offline a minute ago, this has absolutely nothing to do with my PhD. And as somebody once said to me, when you're doing your PhD, everything's more interesting than your own research. So here we go. I'll give you a little bit of, so look, obviously testing, in whether it's drug testing in the forensic setting, in toxicology, and addiction, is a pretty vast topic, and I don't really want to. There will be certain areas that I'm sure people are very interested in, and if there are interested areas that we don't cover today, that people would like to see covered for next year, then please let us know, because as I say, there will be lots of things I do not cover, and it'll become pretty obvious which areas I'm not going to cover, and we can certainly get more discussions around those things in 2023, because this is the second last session of the year. I should also add, one of the reasons I am presenting again was due to it being late in the year, and there was a lot of leave being covered by people who were meant to be presenting as is wont to happen in the medical year. A couple of speakers fell through, so that's why you're unfortunately tortured by having me again. I'd like to talk a little bit though about the basic principles. I'll talk a bit about self-reporting and how much results may correlate with that. I will talk a little bit about, outside the addiction sphere and the forensic and tox world, but I will be putting some caveats on that, mostly to talk about how I'm not going to talk about it. And then I'll try and go through all the specific drugs, as well as a little bit on new designer drugs, and so forth. So I remember a few months back, we had St. David from down in Wollongong who talked about Colombo, and Colombo I think is going to become the figure of DARIA now, because I want to point out that whilst the clinicians, whether you're a doctor, nurse, or whoever, are all detectives in some way, but we should be relying on history and examination. They're on top of investigations. Investigations should be used to marry up what we're seeing with some evidence that is what's going on. So you should never let a UDS or anything be the first thing you do and interfere entirely with your clinical judgment and your assessment of what's going on. So I think that's sort of my important preamble and caveat that I wanted to give to everybody here, that investigations, and that it goes across medicine. We do troponins after we've done an assessment of somebody who's got chest pain. We don't just shotgun do troponins, even though we almost always do troponins. But that's not what we should be doing. We should be utilizing these tests to complement our clinical history taking and examination, which may sometimes be limited for various reasons. So I know I've got a wide selection of people from a wide variety of backgrounds here, and some of this will be second nature to people, but some of it will not. So a UDS is a urinary drug screen, and we'll be talking about that a lot today. Sensitivity is the ability of a test to correctly identify disease if it's present, but it is. Specificity is present if it's not, so it's the opposite. Positive predictive value is the likelihood a test is positive when it's positive, and the negative predictive value is likelihood a test is negative when it's negative. When we talk about screens in urine drug testing, we're talking typically about immunoassay. We use immunoassay as a screen. And that's, I guess, to give you another, analogy to work with, we do, it's not quite the same thing, but we do a screen for bowel cancer by doing the stool sample test that everybody gets in the mail once they turn 50. And then really the test for bowel cancer is to have a colonoscopy, but not everybody needs to have that. So we do a screen in the first instance to see if it's even worthwhile doing a further test. And that's why we talk a bit about screens. And so usually they will be something that's high sensitivity, low specificity, because God knows you don't want to miss anybody who's got bowel cancer. Then confirmatory testing in the world of addiction medicine is typically done by GCMS, which has high specificity, variable sensitivity, and so therefore less, less false positives, but there may be some false negatives, and that's particularly relevant when we talk about buprenorphine, which we'll talk about in a minute. And then there's different levels of evidence for cross reactions as well. So what I mean by that is that certain drugs will cause a cross-reactivity at certain concentrations, depending on the drug and the thing that's being tested for. And I'll talk about that in a moment when I talk about how immunoassays kind of work. So I think the picture on the right demonstrates more nicely what an immunoassay does. So G6PD is an enzyme that's in the body. And it's part of blood, and it's used for an enzymatic reaction. And so we can use G6PD as well as a way of doing immunoassay. Now, this is not always how they work and operate. Sometimes they use different things, but this is just an example of an enzyme donor immunoassay. So basically, the G6PD is attached to the metabolite that you're looking for in the test. And so then if there's nothing in the urine, then that G6PD attached to the little attached to the antigen will bind to the antibody. There's no reaction, negative test, easy peasy. What happens if you've got the metabolite in there? So for example, it might be amphetamine. So these black rings represent amphetamine, for example. Then the amphetamine can replace the G6PD that's attached to the assay, that's attached to the antigen there. And so therefore the enzyme reaction occurs. So that's basically how a UDS immunoassay works. And you can already start to see why this can be problematic, because so long as you've got something that looks like a black ring, and obviously it's not a black ring, but something, a chemical structure that's similar to whatever the black ring is, then you'll be able, then you will have the reaction occur, and it will come up with a positive test. And that's particularly relevant with amphetamines. People often hear me talk about how amphetamines are very commonly cause false positives, and that's because of the chemical structure of amphetamines. And that's just me demonstrating that. Chromatography, I don't want to talk too much about chromatography, but basically, we get the material, we smear it across some sort of media, and then we run it through a machine. I mean, that's basically the long and the short of it. And then what we're doing is looking at these spikes that come up. So if you look on the right here, we look at the various spikes that come up as we run the substance through that, across that medium through that machine, and we compare that to a library of substances to see if that particular substance is there. So looking for that. So a spike in that point means that particular substance. That's what I should say, at that particular point and that particular height. That's basically, that's it. So yeah. So for example, substance 43 is one thing here, and substance 29 is another, substance 57, whatever else. Or this may be the entire fingerprint of one particular substance. We won't go too much more into that. I should also mention that Australia does actually have some guidelines for taking specimens and how to process and those results, and cutoff levels for various substances as well. This is obviously very important in things like football and sport and maybe medico-legal issues and forensic issues and so forth as well. And I think so I should point out before I did actually write a book chapter about drug testing in addiction medicine some years ago. You're more than welcome to go and read it. I should probably put a slide in promoting it. But basically, before I did that, I had no idea that these existed, and I would imagine the vast majority of people don't. So it is worth knowing about, and I think the alarming thing to some degree about this is just how medico-legally much of what we do in the medical world just wouldn't stand up in court. So you've got to be much more careful when you're doing things that have any medico-legal complication, and that might even be things as serious as a child being removed from a parent or a carer, or if you get involved in legal, medico-legal cases. I was talking to Brendan offline beforehand about taking bloods in ED for people who are drink driving and those sorts of things, and they really the things where these fall apart is in particular the chain of custody. So where the sample is signed for and transferred from each person along the pathway to being assessed, because there's obviously the opportunity for that to go wrong. This is not a scientific, this is me messing around in draw.io, but basically what I'm getting at here is UDS immunoassays, we do a lot of them because they're cheap, and then GCMS, it's a bit more expensive and we don't do as many of them because the immunoassay provided us enough information. Blood GCMS is rarer still. And then, for medico-legally valid blood or urine GCMS, they are very expensive tests and hard to source. You have to send these off to forensic laboratories in Lidcombe or so forth, and they are challenging to get. And there's all sorts of other rules around them. So really, we're going to be focusing here. I'm certainly not going to be talking about any of these things today. Hair testing, saliva testing, random breath testing, all of those things. And they're just not things that I do in my practice. They're not things that are particularly relevant. Certainly, if you go and look on Medline, you'll see a million different tests that people are coming out with now for various immunoassays or GCMS testing for hair in medico-legal cases, particularly where there's cannabis use. It might be a parental custody battle. I'm not going to talk at all about that. You can go and and if people want to have more information about that next year, that's certainly something we can look at next year. One thing I will say though is we do, if you have concerns around a patient in hospital because they've had some sort of toxidrome or something, and you're worried that something might have happened, like they've had their drink spiked, or they've got a toxidrome that's not consistent with the with how they're presenting. So they say, oh, I thought I was just taking some opioid, doc, and they were flattened for 4 days. When they, obviously they're awake when they tell you this, or they say, oh, I think I took opioids and they're, bouncing off the walls like they've had methamphetamines in them or something like that. New South Wales Health does have this PRIZE study. So you do need to talk to your local toxicology service. So St Vincent's, that's Clin Pharm, or other hospitals that might just be the poison centre, and give them the clinical history and see whether or not they think it's worthwhile doing a referral to this PRIZE project. And the referral for that's actually not that hard if that's something that people do want to do. So you call pathology and tell them to keep their urine and their first purple tube, that if you took some blood off them, you contact your local service, as I said, you get the approval to send this off to this PRIZE study. And, as I say, these are some examples of things reasons you might do it. So, they've prolonged for a very long time. So you're worried perhaps about fentanyl or something like this. There's features of other toxidromes, or there's a real discrepancy of what they took, if they're serotonergic or anticholinergic. And I believe we are lucky enough to have Darren Roberts talking in a couple of weeks' time about poppy seed, the current issue around poppy seeds and poppy seed tea. And so I'm sure Darren will talk a little bit more about that project then. So tune in for that. I did want to talk a little bit about self-reporting, because there's been a large number of studies looking at the validity of whether or not we need to do some of these things, because, I mean, in a way, a patient reporting to you what they do and don't take is a test in and of itself. And basically the evidence suggests that if somebody is seeking treatment, they actually probably tend to over-report a little bit. And so people will often, who've worked with me, probably know I tend to be a little skeptical sometimes, especially when around opioid, people reporting opioid dependence that may in fact have issues with methamphetamine dependence. And I would say the majority of the cases kind of fit into this bracket. So sometimes I will get a UDS, or typically I will get a UDS looking for opiates, in patients seeking treatment for that. Whereas, for other things, I may or may not. Overall, but I think the important thing to point out here is the negative predictive value is 80%. So if a patient or person says, I don't take, I don't take this, then 80% they probably don't. But of course, there still is a percentage that do. And so that's the time when you think, well, I think this does kind of fit in with, opioid toxicity or withdrawal, and I'd like to look for that. So that's not to say don't do it. I'm just saying that patients, often are reporting correctly what they are taking. I won't focus too much on this. This was somebody sort of saying that, urine, this is a lesson in data manipulation, but basically these people were saying this, that self-reported drug use had poor sensitivity. But when you go through and actually crunch the numbers here on negative predictive value, it's actually very good. You don't need to go through all of this, but you need just me to know. You need me to highlight the important bits here. And these numbers all up here in the top left corner are basically showing you that those who said I'm not using opiates, cocaine, or benzodiazepines actually had urines that said I'm not using opiates, cocaine, or benzodiazepines. And certainly there was perhaps more people who said they were using opiates, cocaine, or benzodiazepines than in fact were negative than there were people who said they weren't, and they were. So if people can follow that logic there, it's kind of a hard thing to explain over telehealth, but I hope that makes sense to people. And I'm happy to go back through that later if you like. So we tend to do them a bit in ED, and as well, when patients come in, and look, in all honesty, they don't, and look, a lot of these studies in ED tend to just focus on the patients who sort of come and go from ED, so they may only be in for a few hours. Doesn't really change a lot in those patients, and also as well doesn't change too much in psychiatric patients. If a patient's reporting an issue with substance use, of course we're happy to come and see them, and a UDS isn't going to change a lot. And of course there are times when it will change things, like I talked about before, particularly when there's a toxicological issue. It tends to be more of an issue rather than anything, but it can sometimes be important in the addiction setting. But often by the time they're piecing together that there's an addiction problem, the patient may well already be admitted. So as I said, usually it's something to confirm a diagnosis when the history doesn't corroborate. And also if the patient's, seeking treatment, that's usually the important times to do it. If we're doing them to try and catch people out or whatever else, they're probably of less benefit. Again, highlighting Mr. Colombo here. So, people want to obviously know, how long will this stay positive and that stay positive? And they may want to know that for their patient's benefit. They may want to know for their own benefit. Who knows? But you've got to remember all of these things come back to the basic pharmacological principles that we have for any drug. Drugs are absorbed, they're distributed around the body, they're metabolized, and then they're eliminated. Drugs have various half-lives, as we all know. Methadone has a very long half-life, heroin has a very short half-life. So the chances of you detecting methadone in somebody's urine are much, much higher than detecting heroin. Not buprenorphine. Buprenorphine is also very long half-life. So yes, your chances of detecting something will depend as much on the drug as well as what it, and then on that, so how much it's distributed around the body. And cannabis is a very good example of that. So cannabis is great at getting into people's fat. And so people have almost reservoirs of cannabis and its metabolites in their system for weeks and weeks after they've stopped smoking cannabis. Dose is obviously important. So the more people use, the more likely you are to detect it. That goes without saying. And again, how long people have used it for. So if I've smoked one joint, pretty unlikely you're going to detect it a week later. But if I'd, been lighting up every lunchtime in the tea room, well, not only would I probably have been fired by now, but you'd probably find that I have cannabis in my urine in about a month's time. Yes, volume of distribution, that's what I've talked about, especially with cannabis. Bioavailability of the drug, so how much of the drug actually will get absorbed into your system, and half-life of the metabolites as well. And diazepam is a good example of that, because some of the metabolites, in particular nordiazepam, have very long half-lives, as do a lot of antidepressants as well, for the record, but benzos is the ones that are relevant here. Amphetamines, look, do with this information what you wish. If you take lots and lots and lots of vitamin C, you acidify your urine, and that makes it much easier to weed out amphetamines. I'm not telling you how to pass a drug test. I'm just telling you information that I have come across in my travels. And again, but I think it's a very good example of how, what we do to our body and what our body's state is. We all exist with a pH of around 7.4, and if we acidify our urine, then we can actually change how quickly we actually wee something out. So it's a very good example of that, and then is relevant as well for lisdexamfetamine if people are studying that or anything else. Amphetamines are particularly interesting in that their chemical structure is very bland. So it's 1-phenylpropan-2-amine, and then all it takes is a subtle little tweak of that chemical structure to create all sorts of fun things. And that's why, once upon a time, the laws in Australia were that amphetamines were banned, and the baddies could say, oh, but I'm actually using this substance that isn't amphetamine at all. It's bamfetamine, or it's wamfetamine, or it's 1,2-amphetamine. And then, of course, Australia went and did the smart thing that New Zealand did, which was change the law to basically say, well, you actually have to prove that this is a safe substance rather than a dangerous one. So so basically there's lots and lots of variations on this, and the assay will detect many of them, whether it's methamphetamines, MDMA, MDA, and it's interesting if because what I mean by chiral molecules here, if you're reading the slides, basically that means the mirror image of each other. So the D form of amphetamines is amphetamine, but the L form, believe it or not, is in Vicks VapoRub. Now, I don't believe that putting Vicks VapoRub on will cause you to have a positive urine immunoassay, but just something to be aware of. So amphetamines have a large amount of, and I'm always, we do get a lot of these in hospital. Patients come in and everybody's a bit frantic because their urine's tested positive for amphetamines. And it's certainly the one I will always ask for a confirmatory GCMS first. But before anybody gets too panicky about anything. And certainly there's a lot of other things that can cross over with it. Atypical antipsychotics being the big one, and that makes it pretty challenging, because if you've got a patient that's psychotic, they may well be psychotic because they have a diagnosis of schizophrenia, or they may be using substances. So it can be very challenging, and so the amphetamine immunoassay perhaps has a limited role sometimes. Designer amphetamines are a challenge. So this is looking at, these are more complex chemical structures. They're not as simple as the simple amphetamine classes that I was talking about a moment ago. This is things like methadone, methcathinone. You may have heard these called bath salts or whatever else. Many of these can be detected via GCMS, but they won't usually be detected by immunoassay. So if you're looking for these things, then you probably do need to send that off to GCMS. One thing I had failed to mention earlier, and I apologize for that, is obviously urine immunoassay is quite easy to get. It's available in most laboratories, in hospitals, and even smaller centers as well. And there's point of care testing with cups and so forth. Getting GCMS does require a laboratory that will specifically do that. So for example, I believe St. Vincent's GCMS is sent off to Liverpool Hospital, which is where a number of Sydney-based hospitals do send their GCMS testing to. There's a few others that send that I'm particularly aware amongst our telehealth sites that actually send them through to Westmead. And then there's a very small amount that actually send them through to, I can't remember where, some far west do send them somewhere different. Again, so again, I just do want to make that clear that, again, part of the reason it's not just cost, it's also ease of access of getting these tests as well. Benzos are a particularly challenging one because the metabolism of them is interesting. So diazepam is broken down into nordiazepam and termazepam, which is then turned into oxazepam, and then glucuronided into a conjugate and excreted out of the body. So therefore, diazepam, people taking diazepam can have termazepam in their system, so they're not actually taking termaz as well. Potentially, they might just be taking their diazepam. But then, of course, there are a large number of other benzodiazepines that might be missed on the immunoassay, and so the classic ones are sort of alprazolam or clonazepam or flunitrazepam, so forth, which can be missed on the immunoassay. Again, they have a variety of times that they will stay positive for. For example, we once had a patient who had been put on a tapering regimen and then was admitted to hospital after stopping their benzos sort of 3 or 4 weeks earlier. And they denied point blank they'd used anything further, and then it came up on their UDS that they had benzos, and then we sent it off for confirmatory just to see, and it was actually just some nordiazepam metabolites. So do be mindful that it does take some time. If somebody's been using diazepam for a long period, that can stay positive in your system for quite a number of weeks. And there's a few things there that will cause false positive in particular, probably worth noting, sertraline as well. Another thing, I keep remembering things I've forgotten to tell you, apologies for that. When it comes to whether or not a thing causes a false positive, there is different levels of evidence around that as well. So the reason oxaprozin is starred there is I believe that there's only been like one case report ever, and nerdish me that I think I dug out that case, and it was pretty crappy. Like, I think the patient was probably actually taking benzos. I don't think it was a case of them taking oxaprozin. So there's varieties of evidence as well when it comes to the things that can cause a false positive, and it may be, as I say, it's chemically looks the same, and so therefore that's probably pretty good evidence. There might be a vast body of evidence, like 20 cases where there's been something that, where it's been shown to be cross-reactive. They might have undertaken tests in a lab, so they might have actually got somebody to take the drug and see if the test's positive, or it's got a series of people to do that. They may well have even just tested the drug straight into the immunoassay itself. They may well have run it through a gas chromatography. There's also but the weakest is certainly if you've just got one case in a case report. That's fairly weak evidence of something being cross-reactive. So just to keep that in mind as well. Cannabis, another really interesting one for reasons I've already talked about. It's incredibly lipophilic, so it seeps out into your tissues. Usually, if you just use it once, it will only stay positive for a short period. If you're using it chronically, then you potentially will have it in your system for a much longer time. The issue of passive smoking, it certainly has been demonstrated. It is possible to test positive to cannabis from passively smoking cannabis. That is true. But like I say, they have got cutoffs for various substances, like we talked about a moment ago. So I'll just go back to where I had that, just to quickly demonstrate that point again. So if you see down here, the cannabis cutoff is 50. It used to actually be lower, and my understanding is that was done because they were able to demonstrate that people who were passively, who were around people smoking cannabis had sort of falsely tested positive to cannabis, and so that's so they raised the threshold, so to speak. So again, but then by the same token, there may be people who are using cannabis that aren't caught at that threshold, or caught, I shouldn't say caught, but aren't detected at that threshold. So again, you've got to understand some of the limitations of all of these tests as you do them, that they are set at certain levels for various reasons, and we'll talk about opiates and that issue in a moment. There's some false positives. The baby wash products I've asterisked. I'm digging out the recesses of my brain to remember why that was relevant. I think there was a case of somebody who was denying using cannabis, but then it was turning up positive, and it was a parental custody battle. I'm not convinced that one was true either. Prescription cannabinoids is an interesting one. So dronabinol will, if anybody who's prescribing prescription cannabinoids, nabilone will not, just for your reference. So Sativex, yeah, nabilone, no. Synthetic cannabinoids, again, it falls into this issue like the synthetic amphetamines. They're very difficult to detect because they're continually being structurally changed. They're highly potent, so the concentration needed to get a high is lower, and they're metabolized very quickly. And there's so many of them that by the time they come onto the, you've done it, the sort of thing we can't make an immunoassay for, because the time we do, they've moved on to the next synthetic cannabinoid. And also at the same time, trying to get the GCMS library of these things is challenging as well. Opioids. So obviously an appreciation for the difference between synthetic and natural is important. So really the only really truly naturally occurring opioids are morphine morphine, codeine, and to some degree heroin. Some people would argue that heroin has been processed to some degree, but when we're talking about the semi-synthetics, we're really talking about things like oxycodone, and then when we talk about the fully synthetic, we're talking about methadone and buprenorphine in particular, maybe also fentanyl as well. And so the immunoassay is really geared to the naturally occurring ones, so that's morphine and codeine and heroin. Heroin is metabolized pretty quickly to 6-monoacetylmorphine. Detection of 6-monoacetylmorphine is pathognomonic of heroin use. It is basically impossible to get otherwise. So if you detect it, and I have seen it in urines before, and I've seen it in urines both clinically and in research. So you can do it. You can capture it. It's uncommon. It basically means the person probably used heroin within the last hour of seeing you or so. So it's pretty quickly out of your system. Some people, the question about codeine and morphine is an interesting one as well. And look, I'll talk about it here. This gets a little bit confusing because we don't usually do quantitative levels of morphine and codeine, but if there's so basically, morphine and codeine can both sort of metabolize each way. But as you see here, it's more likely that codeine will go to morphine than morphine will go to codeine, even though there is some metabolism from morphine to codeine. It is much more common that codeine goes to morphine. I know that when we're at med school and everything, there was the whole concept of morphine going to codeine. But if you detect codeine and morphine, it's pretty likely, it's more likely that they use codeine rather than, I mean, they may well have used both for all I know, but it's more likely they use codeine to morphine rather than, morphine that was, made into codeine. I won't linger too much on that one because it gets a bit confusing. For all of you Seinfeld fans, look, this was a legit issue. Poppy seeds, and look, maybe Darren can talk a little bit more about this in a couple of weeks' time when we talk about poppy seeds in this forum. But poppy seeds can cause false positives because, again, that's what Papaver somniferum, it's the opioid plant. So, and as you can see in the USA, the threshold for detecting opiates is much higher than in Australia, and I do wonder if that's not the Seinfeld effect. And then if there's a variety of sort of antibiotics that are rarely used that may also send a positive as well. So as mentioned, methadone, buprenorphine, and fentanyl will not. So just quickly, actually, I'll just quickly show. Oh, did it? There it is. Sorry, I just wanted to quickly show you that this is a UDS from a different center, not from here because they look different at St. Vincent's. But this is actually a person on buprenorphine, and that is a perfectly normal UDS immunoassay result for somebody on buprenorphine. I'll just go back. Sorry. So you do, if you do want to detect buprenorphine, you do usually have to send it off for GCMS. There are some places I've noticed that a few of the telehealth sites have a buprenorphine immunoassay, which is nice. Methadone we'll talk about in a moment, and fentanyl again, same thing. Methadone, we actually test, usually the immunoassay will actually detect for EDDP, which is 2-ethylene-1,5-dimethyl-3,3 diphenylpyrrolidine. There you go. So, and the reason for that is because, you have to metabolize methadone to get that. And so patients can theoretically spike their urine with their own methadone supply. So it's to sort of circumvent that, so to speak, for all you Arrested Development fans. It usually stays positive for at least sort of 2 to 4 days. And quetiapine and verapamil can cause false positive. There is a case, there's a chap I've been seeing in the telehealth world that had this a few weeks ago, and we've asked him to repeat this. As you can see from the results here, the methadone was on immunoassay negative, but positive on GCMS. So that would be very much fitting with them spiking their urine because the immunoassay hasn't picked it up because there was no EDDP, but the GCMS will have, because it will have picked up the methadone, but it will not have picked up. It did not pick up any EDDP, and I specifically did ask the laboratory to have a look for that. And then, of course, on top of that, they've got buprenorphine. Why anybody prescribed methadone would want to take buprenorphine, I do not understand. But nonetheless, I'm not sure they entirely did, because there was no norbuprenorphine in there, and we'll talk about that in a moment too. I won't linger too much about methadone serum. Because, I mean, you do need to do methadone serum levels. So this is one of the few blood tests that we do, in the world of addiction medicine outside of alcohol. And I'm not going to talk about alcohol and the tests involved in alcohol right here, right now. We can talk, I can save them for another time. But yes, there's no real, we don't really do them that often because there's no real clear plasma level at which it's effective. But sometimes we do use it for people who are rapid metabolizers, and I'm aware there was a recent case of somebody who I do suspect now probably was a rapid metabolizer, because they were on carbamazepine, which is a CYP3A4 promoter, and so therefore and some other results I've had in research I've done has shown similar. So nonetheless, looking across them, studies around methadone troughs and so forth are not great. Some say it's a good relationship, some say it's not. Some say it's good if a dose is less than 80, and beyond that it goes a bit out the window. To give you some example, this is methadone troughs from my microdosing study, which people might be aware of. So obviously, for those who don't regularly do linear scatter plots and so forth, the dots, you want your dots to be as close to the line as possible, and as you go up the line, they do seem to get a bit further away from the line. They're a little bit more clustered around the line at the lower dose here. So at the lower dose here, and a little bit further away here and here. So suggesting that perhaps that is correct, and that was borne out by me sort of dividing them out. So it's not a great relationship at below 80, but it's an even worse one over 80. There's almost no relationship between what their trough level was and their dose of methadone. Fentanyl, as mentioned, if it really does need a specialized lab. So if you're worried about that, then the priors information I gave earlier is really where you want to go from there. And there is public health implications for people with fentanyl. So do take it seriously and refer off if you need to. Buprenorphine. So as mentioned, it's dealkylated to form buprenorphine, in which are both of those things are gluconidated. So you get 4 main metabolites. Something that's not routinely done, but I just wanted to touch on quickly because I think it's interesting, is norbuprenorphine-buprenorphine ratios. And so really they should be greater than 1. And again, this is potentially another way to detect spiked urine. And they typically stay positive for around 4 days. So this was some research we did at I did with some docs over at RPA. We took 20 patients on buprenorphine, and we watched them take their dose. So they took it. They then did serum and urine GCMS, as well as some immunoassay, but we also sent it off to a forensic lab to qualitatively look at how much buprenorphine was in their system. So we did it at time 0, so just before they'd taken their medication, at 2 hours, 4 hours, and 6 hours, sent that away. And what you can see is, there's a really big spike in that first 2 hours, but then it flattens out to really what it was almost pre-test with the buprenorphine. The norbuprenorphine levels are much higher. You can just sort of see that it's on average, they're really above 400. So potentially norbuprenorphine is a better marker. And so perhaps this is something we need to be looking at more if we do want to detect buprenorphine. But overall, the qualitative, so when I say qualitative, that just means yes, no, and which was basically the test that we do out at Liverpool, and what you'll get at most GCMS results. It'll just tell you, yes, it's in the system. It won't go and measure how much is in there. You need to usually send that off to sort of forensic labs to get that. But basically, over half were negative, which was pretty eye-opening, and many of those are on people greater than 8 milligrams. It was almost undetectable on patients. So we had 2 patients in the study that were on 0.8 or there was one on 0.8 and one on 0.4. And none of them tested positive at any point on the test out at Liverpool Hospital. What was I going to say on the qualitative UDS? Quite a number of them were negative as well, and even on the blood samples, quite a number of them were negative. So, and unsurprisingly, low blood and urine levels correlated with a negative qualitative GCMS. So hardly surprising. But again, I guess the big thing that I think came out from this study was that the norbuprenorphine ratios were a very good marker of people taking their buprenorphine. But especially in patients. So if you've got a patient on a dose over 8, and they really should have a norbuprenorphine ratio of greater than 1. And if they don't, then perhaps they're not taking it. So just an interesting little thing that came out of that. Cocaine is a very specific immunoassay. So it's probably the most specific of the immunoassays. So if it's positive, because it's really only got the one major metabolite, which is benzylcognanin, which is what they test for, it's very, very specific. So usually if it's positive for cocaine, not that cocaine use is that rampant in Australia, it does usually mean that that's positive, and that can be relevant, in patients perhaps with heart issues or so forth that come in to hospital as well. GHB is a really challenging one because we produce it and it's got such a short half-life, and there's no immunoassay for it. It needs GCMS, but usually by the laboratories that offer it are mostly forensic, and it's just not something that's routinely done. And most, not even 99%, 99.99999% of GHB overdoses in Australia are clinical diagnoses. Almost none of them would be confirmed with testing, except for rare exceptions where it's felt there might be some foul play or something like that. Special K, ketamine, they're all testable by GCMS, and there are some immunoassays coming about, and it's detectable for about 3 days when taken orally, but can be longer as well. And quetiapine, once again, seems to cause havoc with everything. And PCP, we don't have a lot of PCP in Australia, but there's a few things that will cause a false positive for that. LSD as well is also, there isn't an immunoassay available for that too, but again, not commonly used and not usually good reasons to be doing that. So I'll start to wrap up there, but I will sort of finish up by saying, it's still the hierarchy of things is still history, examination, investigation. So do not let your tests gazump your history and your examination. If a person states they don't use something, they probably don't. If a person states they do, then sometimes it can be worth checking. Methadone and buprenorphine testing is tricky, like I've mentioned. So make sure you cross that. And also, when you're ordering these things, do make sure that you request them and talk to your local pathologies about what tests are available. If you just send off a form and hope that it'll get done, you may not get. The information you put in, the information you get out is as good as the information you put in. So, and not just that, the information is also as good as the mechanisms there. And I've spoken to the laboratory people at St. Vincent's, for example, and they're very, very friendly and helpful, and want to get the right test as well. I would say that, in spite of everything I've said, that almost none of the tests that I've ever done would ever stand up in a court of law, mostly because of issues around chain of custody of the sample. And yeah, like I've mentioned, don't let UDS alone guide your decision making. I'll wrap up there, and hopefully there's some questions or concerns or whatever else, and happy to answer questions if there's anybody left listening. There may not be. You may have all nodded off by now.
Thank you so much for that, Chris. That was a really great overview, and I think it actually is very useful to have that level of detail, because such a ubiquitous tool in clinical practice, not just in drug and alcohol. So if anybody has any questions, you can type it into the chat, or while I'm waiting for you to digest all of that. I suppose, given their ubiquity and their limitations, just in clinical practice, Chris, can you let us know what's one thing we should be doing more of when it comes to urine drug screening, and what's one thing we should be doing less of?
Yeah, that's a good question. I'm a big and I was even involved in there's the Evolve guidelines out of RACP now. We want to be doing less pointless tests and so forth. I think we probably need to do just less random UDSs, I think, and probably more targeted GCMS to actually look at to specifying exactly what it is, and talking to your lab and saying, I've got this clinical situation, or like I've got a patient and I prescribe them benzos, and I want to know if they're taking just that benzo or if they're taking other ones, and the laboratory, goes, yep, we can have a look for alprazolam, or we can look for this or that or t'other. So I think probably less just sort of shotgun UDSs and more targeted urine GCMS is probably what I would say in response to that.
Great. We also have a question from Dr. Craig Rogers, who is asking about one of his clients who swears his UDS is positive for amphetamines because the people around him are smoking. What are your
smoking amphetamine? I haven't looked at that so much. I would say possible. I would not rule it out. It is an incredibly sensitive immunoassay. But I'll have a look and I'll get back. And look, that might be something, they've actually done like studies. The way they do these studies is quite interesting to read about. Like they will actually have like windows open, windows closed, and have people almost in like rats, like in a laboratory, in those sort of conditions, and they will test out what's happening. And look, I would say that it's, given how sensitive an immunoassay is, I would say that it is potential. And yeah, and I can see you've written there as well. Yeah, you mentioned can occur with cannabis, so potentially possible. As I say, I think the amphetamine immunoassay is still set at quite a low level. So again, another reason why I think it probably would be possible as well.
Is that something you would go and get GCMS for then? If the immunoassay is being too sensitive, do you want something that's a bit more specific?
I guess it would tell you, it will tell you whether or not it's and the only thing is it'll tell you whether or not it's amphetamine versus I mean, so if they're on another drug, it might be helpful, because if, then you can say, well, it's the other drug. This will just tell you whether or not it's amphetamine or not. So it is hard to, I don't know if it would be that useful, because as I say, like, it's likely to come back positive as well. And the question really is, how is it getting into their system, as it were? I don't know what sort of, then you might look at the next level of testing, which is, I haven't covered it all, today, which is doing that deeper testing of hair or other things where you would expect there to have a high concentration, because there's been a high sort of reservoir of it in the body, so to speak. So that's that would be probably where I would go with that. But good question, and I don't know the answer for certain.
So it might be possible, Craig. Robert May, should we be conducting return of driver's license assessment if the objective information we're using is not medically?
Yeah, no, that's another great question. I think, look, I'm countering some of the things I've just said with the following. Because they are sensitive, they're quite good rule out tests. And like I did say, if a person says they're not using something, chances are they're not. Now, obviously, in a situation where they need the return of their license, then obviously they are motivated to lie. And there's a lot of secondary gain there. But by the same token, if it's negative, then chances are it's negative. Now, of course, then there is the question of, well, have they done something else to potentially just give you a fake sample? So have they brought something in, a sample in with them? And there are ways around for people to do that, such as I won't get into it here. But again, I guess it falls into that thing. Another piece of teaching somebody once gave me was that if your patient wants to deceive you, chances are they'll deceive you. We can only do as much as we can do. I think, ultimately your history and assessment of patients with getting their license back is going to be sort of, particularly crucial. And then the investigations are there to kind of back up, like I was saying, whether or not you think it's worthwhile, if it's reasonable that they return to driving or whatever else. On top of that, there is that issue of public health safety, and your duty to the public, as it were, to protect them from harm. But I don't think we should get too caught up in that. I don't think it's our job to be heroes and saviors. It's our job to make an assessment and say, well, on balance, I think this person probably should get their license back, and here are the reasons why. Whether or not it's worthwhile trying to do more formalized testing, which involves them doing the test in front of somebody, I guess depends on how impaired you think the person potentially is, and how insightless perhaps they are as to the potential of their dependence or harms they may cause. So I know that's a bit of a non-answer, but I do think that I think on the whole, probably for the majority of the time it will be a sufficient test, but there may be occasions where you might have to do something again a bit deeper, so to speak.
Thanks, Chris. Great questions. Anybody else going to take advantage of having a clinical pharmacologist on the line?
And if you ever, I should add, if you do have more questions, a lot of places will have a biochemist, at their facility, and they're great people to talk with. They usually have a bit of time on their hands too, because they're mostly lab based, and so they kind of not under clinical pressures of, that's not to say work's not important and they're not busy, but they don't usually have as much time pressure as, say, calling up your cardiologist or whatever else. So they're usually great for a chat and can give you some information about all those things. So I highly recommend, if there's any questions outside beyond this, and that you're too scared to ask or you think of later, do get in touch with them as well.
Thanks. Good tip, Chris. All right. Well, I'll leave it there for today. Thank you so much, Chris.
Pleasure.
Next week's Daria will be an interesting one as well, with NCCRED's Dr. Penny Hill, who has done a great job of bringing together a prompt response network for Australia with involving clinicians, consumers, harm reduction service providers, and lots of other key stakeholders across every Australian jurisdiction. So tune in next week to see her presentation. All right. Thank you everyone for your time, and I'll just close the meeting.